Hi, it's Dr. Centeno, and today we're going to talk about false negative imaging of the ADI, or the atlantodental interspace. Now, in medicine, false negative means that the problem is there, but the tests don't pick it up. So we're talking today about one kind of CCI, and that is where, from a front-back standpoint, there's excessive C1, C2 instability, or atlantoaxial instability. It can also be picked up through an excessive Grab-Oakes measurement. That's different from some of the other subtypes that you've heard me talk about. So, which ligaments are we discussing? Which ligaments hold C1 to C2? And that's the alar ligaments, or at least the part of the alar ligaments that go forward, as well as the transverse ligament. So transverse ligament is in here, and the alar ligaments over here. And they're both holding the dens to the atlas. And this is a more simplified version of that. Here's the transverse ligament down here. Here's the alar ligament. And this is the dens, and that's the tooth-like portion of C2. That's all of C2 that's shown here. And this is C1. So the dens is C2, and that's C1. And if we get the patient in a position where they're looking down or flexing their neck, the atlas wants to go forward, but these ligaments here are preventing that from happening, as are these ligaments. So that's what we're talking about. Basically, is that the dens is moving too much because the ligaments that are supposed to prevent it from moving aren't doing their job. And we measure that on X-ray or MRI as the atlantodental interspace. Basically, the amount of distance between the dens of C2 and the atlas, or the front of the atlas of C1. And it should be 1 to 3 millimeters. Now, so here's an interesting case, and I've seen a number of these. So this guy has a atlantodental interspace on MRI of 2.5, so it's within that range. And even when we stress him on a DMX inflection, he still only has about 1 millimeter, maybe 1 to 2 millimeters. So both of these would state that this guy is just fine. He's got no issue with his atlantodental interspace or transverse ligament and alar ligament inflection. However, you put this guy to sleep to do, in this case, the PICL procedure, and the needle's coming from here for the PICL procedure. And now we see much more motion. In fact, we know from his MRI that that's 16 millimeters wide. That's the dens. So this is about 7 millimeters at least of ADI. It opened way up. So what happened? Why would we see it in this case, but we're not seeing it on the imaging? Well, the patient can use their neck musculature to stabilize C1, C2 with normal motion. And most of the patients I've seen who have this are pretty young. So youth is good here. But that's not foolproof, as once the muscles are taken out of the equation, such as the patient goes to sleep or if their movement is sudden and unprepared, they tend to get instability, and that causes their symptoms. Now, in this case, we put the patient to sleep, and there were forces in neck flexion, and so the muscles were taken out, so we saw it during the PICL procedure. And I see this in about 1 in 5 PICL patients. About half of those show some mild increases in their ADI, but the other half have these dramatic increases in their ADI. So what does this change for us? Using the PICL procedure, we can focus here heavily on the transverse and anterior bands of the alar ligaments to try to get those specific ligaments to tighten down. And again, PICL procedure is when we're coming in from the front using endoscopy and x-ray guidance to get into those specific ligaments and inject the patient's own bone marrow concentrate to heal those ligaments. And we can obviously also reassess at subsequent PICL procedures to see if what we did helped. And one of the other things that this will change is for those patients who seemed to have the problem, meaning, it looks like a duck, it cracks like a duck, but they don't have the measurements to classify them as CCI, it may be worth putting them to sleep in this position and doing nothing other than observing that ADI to see if we can get the ADI to show abnormal. Now listen, it may be normal, in which case they don't really have CCI. But this shows that there can be false negatives and that sometimes you'll have to go and put the patient asleep to make sure there isn't a false negative. So if everything else lines up, that may be something we do in select patients. So thanks so much for watching today. Again, I enjoy doing these videos as we see various things so that you can get a sense as a patient with this problem, what we're doing, what we're researching, what we're thinking about, and as we learn it, we like to get it out there. So thanks for taking your time today.